I have not seen a room like this filled with real humans in a super long time. But this is a testament to, I think, how you feel about today's presenters and really getting them because they're outstanding. Today we're talking about psychological safety, and our presenters are outstanding conveyors of the psychologically safe environment. Today we have Dr. Chad DeMott. Dr. DeMott is Associate Professor of Internal Medicine. He is also Clerkship Director for Internal Medicine and Associate Program Director for the Residency Program. So he has lots of experience making learning environments psychologically safe. We also have Dr. Aubrey Knight, who is full professor at the Community Tech School of Medicine in both internal medicine and family medicine. He is also the senior dean for student affairs. So as you might imagine, he has tons of experience in this area. Please join me in actually putting your hands together and welcoming these.
Thanks, Sherry. And Chad and I are so excited to be talking about this topic, but more importantly, doing it in a room where there are people that are sitting here that can engage with us, that can shake heads and give us weird looks and help us to know whether we're on target or not. And we do want to make this a dialogue with the audience. And while we obviously have some slides and want to project them and want to introduce a couple of concepts to you, we do want this to be a dialogue, and we'll commit to saving some time, if not in the midst of, certainly by the end, so that we can talk through some of these things. I think we all recognize and are experiencing that the learning environment is changing. The ways in which we interact with students can sometimes cause us to pause and wonder, is the way that I've taught. I've been teaching for a lot of years, and is the way that I've been teaching through the years no longer applicable to students today? And I would suggest to you that it is, but I think that we do have to be wise and recognize the importance of the learning environment, both for us as educators, but also for our learners. And so what we'd like to do today is to frame that conversation around the concept of psychological safety. So we titled this Psychological Safety in the Learning Environment from both a UME and GME perspective. Maybe not what you think. And our objectives are to, number one, define what we mean by psychological safety, to help you understand a little bit about what the Learning Environment Advocacy Committee is at UTC-SOM. There's a lot of discussion. I'm sure you all, if you've not heard about that committee, from someone else, you've wondered, what is it and why am I so afraid of it, right? And then to kind of wrap it up by talking about how can we make the learning environment more psychologically safe, and how can we do it in a way that provides for learning for our learners. So psychological safety was coined in the end of the last century by Harvard Business School professor Amy Edmondson, and she defined it as a belief that we can share our thoughts, feelings, ideas, questions, concerns, or mistakes even, without fear of punishment or humiliation. It was a business concept, obviously. It was around the teams that exist in the business world. And that team climate was characterized by interpersonal trust and mutual respect. And it was that climate of mutual respect and interpersonal trust that allows for both in the case of the business world, the employer and the employee, but in the case of the learning environment, and specifically the clinical learning environment, the teacher and the learner to feel safe and move forward. So and if it's done well, it enables the team members, teachers and learners, to take risks, to be creative, and to learn from each other. So what we're going to do is let Dr. Edmondson define for you a little bit about what
she means
by psychological safety.
One of the most important factors in delivering safe and effective care is psychological safety. Allow me to define that as a belief that the workplace is safe for speaking up with ideas, questions, concerns, and even mistakes. And it's a sense of confidence that your voice is valued. You can think of this as a sense of permission for candor, that the workplace is somewhere where we count on your voice being heard, because you never know when you will have had the observation that someone else missed that will be mission critical to delivering safe, high quality care. Now, I want to be clear that psychological safety is not about being nice. It's not about holding back on something you think might be unpleasant. In fact, quite the opposite. It's about candor. It's also, of course, not freedom from conflict. When you're in a psychologically safe workplace, there will be conflict. People will have different points of view, and we'll get into it, and we'll seek to understand each other's views better and come out with a better solution. Psychological safety and a psychologically safe workplace doesn't mean that all of your ideas will be applauded. And it's certainly not permission to slack off. It's not a license to whine. It's not oversharing. We still want people to be thoughtful and considerate in sharing work relevant content. And important to mention, psychological safety isn't the goal. Psychological safety is a means to the goal, and that goal is excellence. That goal is commitment to high quality care. So it's important to recognize that for really high quality care, you need not just psychological safety, you also need urgency and commitment to excellence. If you don't have either psychological safety or a commitment to excellence, then you are working what I call the apathy zone, where your heart isn't in it, you don't much like your colleagues, and you're just not giving the work what you could give it. And certainly if all you had was psychological safety and no commitment to excellence, then you'd be in what we call the comfort zone, where it's quite a relaxed state of affairs. I know that that's not characterizing care delivery today. However, this is the one that worries me. When your commitment to excellence and your sense of urgency are high, but psychological safety is low, I call that the interpersonal anxiety zone, where your commitment to excellence is thwarted by not feeling that your voice is welcome. So finally, if you have both psychological safety and a commitment to excellence, that's the learning zone, that's the high performance zone. That's where problems get solved day in and day out, especially in healthcare delivery.
All right, so thank you for coming. You guys got the handout. This was copied with permission from somebody that, if you like infographics, it's a lot of information, but it's based on Amy Edmondson's book. So if you want to get a summary of her book that she wrote specifically about psychological safety, someone did this for her, and I contacted them, got permission to print it out. So and it's got like all of these aspects on that. So I want to get this all the way across. This is not just being a nice person, everybody's kind, everybody's sweet, but we never disagree. That's not psychological safety. And psychological safety is everybody's kind, everybody's nice, but we don't care about excellence. We don't care about making good decisions. That's not what we're talking about as well. We're talking about framing it in a way that everybody has a voice and that and everybody can get their voice out. And I don't care where the voice comes from. If it's a good idea, it's a good idea. I was reminded of this. I'm going a little bit off topic, but you'll get used to this. So I was reminded of this. I saw a trailer for a movie, and it was back, I don't know, it looked like in the 70s. I didn't pay attention too much. But they were set in like the 70s or 80s. And the custodial guy of Frito-Lay had a good idea for a chip flavor. And he ended up like calling one of the high-level executives. And he's giving this, and he goes, well, who are you? And he's like, well, I'm the janitor or something like that. And I remember telling my wife, I said, that's exactly what this is about. I don't care where it comes from. If it's a good idea, it's a good idea. It's a bad idea. If a bad idea comes from attending, I don't care how good they are or renowned they are, it's a bad idea. If it's a good idea and it comes from whoever, we should be willing to embrace that. And that's all about psychological safety. So some things to start off with, setting the stage. So these are the 3 factors that this would include, and you heard that in her speech. Setting the stage, purpose and expectations. You destigmatize failure and risk. You want to set right up front. I want you to get it out there. I don't want you to be afraid of offering suggestions. I don't want you to be afraid of saying things. Some of the best things I've ever heard on a war team were by students that I've been so far away from the physiology and pathophysiology that they said something and I'm like, huh. And then you look it up and say, well, that's pretty brilliant. You know, but if you just discount them because of their junior nature, you're going to miss that. Or if you create an environment where they can't feel free to speak up, they're not going to speak up. And you're going to miss good care and excellence for the patient. So setting the stage, inviting participation, all voices are credible, and the team is open to change. I'll talk about this on my personal stories later on kind of what I do to invite this, but inviting participation, letting everybody know on the team that we want to hear from you. When we don't hear from you, we're all at a loss, and you're saying that out loud so they can hear it. And then responding productively, express appreciation and lay out next steps. So this is not always that you have to agree, like this is a good idea. They might be wrong. It might be wrong, but you can tell them it's wrong and here's the next steps, or here's what we want to do, or here's what we want to go. This is not a meeting. My pet peeve with meetings, people that know me know I'm not a big meeting guy, because they tend to, Dr. Sweet's laughing, because they tend to like go on and on and on. There's never next steps, and what are we doing here? So and you say, well, that's psychologically safe. That's not psychologically safe. Not for the person like me that I don't want to be there if we don't know what the next step is. Like, tell me what the next step is. Tell me what the actionable item is, and then I can get behind that. So this is all, so if you get like, it's not what you think. It's not just about being kind. It's not just disagreeing. It's disagreeing, but being free to disagree, and how we disagree and how we express those things. So this is one of Dr. Knight's slides. So trust and psychological safety. Trust and psychological safety, they're similar, but they're a little bit different. So will you give others the benefit of the doubt when you take a risk? Will you give them the benefit of the doubt? I would say you can have a psychologically safe. You don't have to necessarily trust somebody to make sure to hear their opinion. Like, I might not be at a point where I'm trusting them, but boy, I want to hear their opinion. Because even if I don't trust them, even if I don't like them, I want to hear their opinion. I want to hear all opinions. And psychological safety has to do more with, will others give me the benefit of the doubt when you take a risk? So when I take a risk, when I step out and say something, will I get swatted? And then guess what? I'm never going to say anything again. And you probably can all think of a time when you were in a meeting or a department meeting or an occupation or hopefully a previous employment, where it's like you had a boss that was just what the boss wanted to do. And you know what happens? You just stop talking because you're just sick of getting swatted down. And that's not psychologically safe.
And setting the stage is what allows that to happen, when you do feel that others can trust you when you step out there. And this is another of those graphics that I found as I was looking at learning about this a little bit more. And there's if you think about it at one level, it's like, I want to be comfortable and I want to be safe, right? I want everything. I want to be up in this quadrant. But in reality, you want to be down in this quadrant. Maybe not down here.
Probably closer to
but
here.
You want to be in this quadrant, kind of over the safe, but a little bit with a little bit of discomfort there. And we want our students to be over there.
Those are the meetings that don't go anywhere, right? You want to press people, but you want to do it in a safe, kind way. So, right?
Yeah, exactly.
Okay, so really simple. I call this the transcendentals of education. So if you study philosophy, you know about truth, goodness, and beauty. And and if this sounds familiar, like if we go back, expectations, questions, and feedback. Now you go back to what we said about expectations, questions, feedback. And it ties in. Psychological safety is all about how we do that, right? So I can ask questions till I can keep asking a student or resident questions until they're in the corner, like rolled up, rocking back and forth because or I can do it in a way that, hey, that's the wrong answer, but here's where we went wrong. Here's where we're going to get you right, right? You can do it in a kind way. Expectations for the team, and then feedback. Not just you're doing fine. Doing fine is like the worst thing you can tell somebody because it doesn't tell them anything. It doesn't get them to the next step. So a psychologically safe environment would be like, I'm going to tell you how you can get to the next step. It might be some things that you just don't want to hear, but that's okay. Within the trust in a psychologically safe environment, you can get to those next steps. So remember, expectations, questions, and feedback, it's the same for psychological safety, but there's more of a how component to it.
And the way Chad described that of when he tells the student or the learner that, I'm going to tell you something, you may not want to hear that, before they tell them something that they didn't want to hear, is again, setting the stage. And that's a key component to this.
Okay, so psychological safety, what it's not, and you heard this in the video, it's not an end of itself, because then you get into nowhere land. So this is, everyone is happy, but the company's going into the ground. That's not good, right? We want to, you got to press people a little bit. They got a job to do. They got expectations. And it's expectation. If you don't do your job, then the company or the organism or whatever that is that you're looking at is hurting. And that's a bad thing. So we want everybody to be part of the process. And when they're not a part of the process, that's bad. So it's not just, hey, it's an end of itself. It's an end of, the reason why Google and big companies do this type of behavior is because they want to produce a product that's really good, right? They want to have an end product, or they want to make money doing and selling their product. And it's the same with healthcare. We want to provide excellent healthcare and excellent education. And psychological safety is one of those ways that we can kind of ensure that's going to happen. It's not simply about wellness or niceness. That's why I said it's not what you maybe think what it is. This is not just like everybody's well, everybody's kind, we're giving out cookies. Because this might be in some meetings. And really, if you've seen a meeting where everybody trusts each other, but yet there's discourse and argument. This happens with me and the program director quite often. Like we'll have internal medicine, so we'll disagree quite a bit, but we do it in a way that it's like total respect for each other, and we go with an understanding of what the other person's trying to understand. And when you see it done well, it's a thing of beauty. Okay, so you can disagree on things and still be respectful and validate their opinions and look at it and try to hear it from their side. So it's not simply about wellness. It's not avoiding conflict. It's quite the opposite. When you move, there's conflict and there's friction. There's people that are going to have different opinions on how things should be done. And that's okay. And that's what you want, because you don't want everybody, if on my team, if everybody is saying the same thing, I get a little bit nervous that I'm making a mistake, that I'm not seeing all of the possibilities. And it's not word diarrhea or oversharing. So this happens in meetings too. When you come to the table, have something to say, but just don't talk, just talk. Because that goes nowhere. That's not a commitment to excellence as well. So it's inviting all opinions, but it's understanding that if somebody's dominating a conversation, then other people are not getting their opinion out there as well. So
we talk about the clinical learning environment as we talk about psychological safety within what we are doing in teaching students and teaching residents and involving people in the clinical learning environment. I would suggest to you there are three primary stakeholders, and that there are stages or ways in which we should be or can be safe. And the three stakeholders are not just the teacher and the learner, but also the patient. We are with the patient as we are in the midst of this clinical learning environment. We need to feel included and include others. We all should be collaborating in this, teachers and learners alike. And we all should be, we as teachers should be empowered to challenge, and students should be empowered to challenge as they're learning. So, so in a psychologically safe environment, the learner should feel safe to discover, to learn, right? Should feel safe in asking questions, should feel safe in saying, I don't know. And getting to the end of that barrage of questions that Dr. DeMott is asking until you get to the point where I don't know, and feel safe in getting to that point, and not cower in the corner. To feel safe in experimenting, experimenting with the ways in which they present their patient presentations, experimenting in the ways in which they are interacting with the patient. They should feel safe in that, and then safe in learning from their mistakes and not being made to feel less than because of a mistake that they've made. Similarly, as teachers, we need to feel safe to ask questions. We should not feel uncomfortable because we're afraid the student is going to report us to the Learning Environment Advocacy Committee if we ask them a question. We should feel safe in sharing our experiences, in sharing our successes and our failures around the kinds of things that we're seeing. We should feel safe to challenge the learners. And as Chet so rightly explained, we should be setting, not just feel safe, we should be setting expectations and providing constructive feedback. But the third player or stakeholder in that clinical learning environment is the patient. And we as teachers and as learners, we need to recognize in the midst of this complex thing that we do in bedside teaching, that the patient that we're teaching is vulnerable. They may have a health literacy that's different from ours. So as we teach, recognize, and if we're teaching a learner but wanting to convey something to the patient too, recognize that there may be some health literacy issues that need to come up. Recognize the background and potential preconceptions or misconceptions of the patient, and our need to clarify and ask for questions for understanding for those patients, and to allow the patients to clarify and also ask questions.
I think it's important too, I'll just comment that it's okay to say I'm frustrated and then explain why you're frustrated. So when a patient's frustrated, it's okay, just invite their frustration. Like, tell me why you're frustrated. Or as the teacher, if something's not going right, or there's haphazards, or there's like system problems, it's okay to say to the learner, I'm frustrated because I feel like this could be better. It's not that you're making a barrage against the institution or railing against the way things are, but you're saying, I'm frustrated because I think this can be better. Now, how are we going to make it better? So I think opening that up and allowing when the patients are safe, they can be frustrated and you don't take it personally. They're frustrated, they're sick, they're in a vulnerable position. Yeah.
And also, as pertains to the patient, we as the teachers or the educators sometimes are going to need to ask other people, and when we sense that frustration or sense that we need to have a conversation with this patient without the rest of the audience there, to have permission to say, would the rest of the team go outside? I need to have a conversation with this patient and not feel like we are, not allowing them to be a part of something that's happening. Yes, we are not allowing them to be a part of something that's happening, but it's something that we are first and foremost physicians caring for patients. As we enter this complex world of the clinical learning environment, we need to convey, we need to feel that we're valued, but we need to convey that every member of the team is valued. And we do that by valuing them and treating them fairly, by allowing open contributions, and by allowing them to sense that their opinions matter. And sometimes their opinions are wrong, but their opinions matter. And there are ways to do that. And I added this little line here that it's a moral imperative that we do that in the midst of this clinical learning environment. Convey to our learners that we are collaborators here. We're trying to take care of these sick patients. And your input is important to me. Engage and interact with them, have mutual respect and access to them, maintain this open dialogue, and foster constructive debate, which leads to openness and trust.
I saw this done really well. You're okay with my comment? I told him I was going to interrupt him a lot. So the collaborator safety, I saw Dr. Gonzalo, I saw him run a meeting the other day with the clerkship directors. And one of the clerkship directors, this particular clerkship director, harps on one idea quite a bit, and I happen to agree with her. But she brought it up again. She goes, you know what I'm going to say, right? And then Dr. Gonzalo said, he goes, it's okay, you're safe. Just say what you're going to say. And it was really a beautiful thing to behold. And then everybody, that's an example of a meeting where everybody's like challenging each other and throwing things out and disagreeing a little bit. But he said, it's okay, you're safe. And that was a beautiful thing to see, yeah.
And then, as we've mentioned in a couple of different ways, giving permission to challenge, to express ideas, to challenge the status quo, to identify problems. And the result of that is creativity and innovation. Okay. So what is the Learning Environment Advocacy Committee? What is this feared committee called LEAC? We wanted to add this in here because this is kind of what we're hearing, is that there's a discussion around, okay, what is this committee, and why am I told to be so afraid of them? So first of all, the LCME requires medical schools to have a means through which students can report concerns in an anonymous fashion. So the students have to have the ability in an LCME accredited medical school to anonymously express concerns about the learning environment or anything else about the medical school. And then students are then asked in the AAMC surveys whether or not they have this ability. Do they know how to take advantage of this ability, and what kinds of mistreatment have they recognized? So and the reason this became an LCME emphasis 10 years or so ago was because of the disconnect between what the graduate questionnaire said, where graduates of medical schools were reporting all kinds of misbehavior, and medical schools were saying we do everything perfectly. There is no misbehavior. There's no or no learning environment, even before there was the concept of learning environment problems going on at our school. So this disconnect resulted in the LCME saying, okay, students need to have a safe way in which to report these things. So and these are the two, I'm not going to read these. These are the two LCME standards which deal with the requirement that the medical school has to provide for these ways in which students can report, and a mechanism through which the school responds to these reports. So that's what the LEAC is. The LEAC is the committee that the medical school has appointed as the committee that responds to student complaints about the learning environment. It is a multidisciplinary committee. It meets monthly. All reports to the LEAC are de-identified. So the committee does not know who reported it, and most of the time, no one knows who reported it because the students must have the ability to report anonymously. Some do sign their names to it, but most of the reports are anonymous, and those who are being reported about are anonymous. The committee does not know either the reporter or the alleged violator of the learning environment. The committee hears the report and determines whether or not this is in fact a learning environment issue, a professionalism issue, or just a student gripe that neither leads to a report of an unprofessionalism or a learning environment concept. And the committee, there are several people who either are on or have served on this committee here today. I hopefully they will agree with me when I say the committee really does take these things seriously, spends a fair amount of time on each complaint, sometimes more time than, I'm not a meeting person either, and some of these meetings go quite lengthy as we deal with these, but I think it's appropriate because we really want to provide the students the ability, but we also want to make sure we're doing the right thing by the faculty. They want to make sure they're doing the right thing by the faculty, and then determining how best to proceed based on the degree of egregiousness, I guess, of the complaint. Questions on that? So how do faculty and students learn about the learning environment, and how are they educated on what this is, and how do students, I guess this slide says, how do students know how to report and what to report? So they, again, an LCME requirement is that every year we must have a face-to-face session with each class. So every year, each class gets this 4 times, is a learning environment session where they are explained what the learning environment is and provided some examples that are, some of them have occurred here. Some of them are reports that were reported here that were determined not to be learning environment, learning environment missteps. And some of them are not from here, but are just illustrative of very good examples of the kind of thing that we would maybe want them to make us aware of. These are discussed as a group. We kind of do this developmentally. We don't talk about clerkship learning environment to the first year students. It's more about the learning environment in the context of the preclinical curriculum. And then the 3rd year orientation, which actually is happening in the next week or two for the upcoming 3rd years, is really does focus on the bedside hospital clinical learning environment to a greater degree. At this point, we have not introduced the concept, or they have not introduced the concept of psychological safety into those, but we probably will do that and probably spin these in a similar way to what Dr. DeMott and I are doing today. Faculty learn about the learning environment at new faculty orientation, and then within your departments, you have routine reminders of them. And I do know that on occasion, there have been twice in the history of the school where the GQ really did make us a little concerned about the learning environment, where there again was a mismatch between what graduating students reported and what we had heard while they were here. So we really wanted to kind of get to the bottom of that. So we actually asked the departments to discuss those in the context of their department meetings. So I put a couple of slides in here that I think are just important, kind of maybe conversation starters or reminders, and this one I titled "Words Matter," and these next two are really some thoughts that I have or suggestions that I would make to you to try and make the learning environment a true learning environment, and not this kumbaya moment of everybody loves everybody else, where we're up in that corner where nothing gets done and no learning is occurring. But words matter. So know the names of those on your team, and ask how to pronounce them, and don't be embarrassed about names that when you look at it, you're not 100% sure of how to pronounce it. If you're not 100% sure of how to pronounce it, ask how you would pronounce that, and then refer to them by that name once you have that. Once you feel comfortable that you're ready for that.
Let me interject here too. For better or for worse, like I try to do this, and sometimes the residents or students, they'll have, it's not their name, but they'll have like a nickname. And they're okay with calling a nickname. What I try to do is, but what's your name? And then I actually try to learn their name. And sometimes it's difficult. Like I'll work with them for a week or 10 days, and darn if I don't try for 10 days. And sometimes it takes me 10 days, and by the end of the 10 days, I'll have their name, and you can see them smile a little bit because you just hung out there and you cared enough to try to learn their name. If you can't get that, that's why sometimes they'll have a surrogate name that they'll use, and that's okay. They've given you permission to use that, but make an effort because it'll be rewarding, and nothing's better than just calling somebody by their given name.
I think we've all been in situations where you've said something and you look at the people that you've said it around, and either their response is not what you would have expected based on what you said, or there is this wide-eyed look, and if you have a situation like that, let me just encourage you to call it out and say, what did I just say that made you have that look? Don't or if you realize you just said something that deserved a look, whether it got a look or not, maybe back down a little bit and say, you know what, I might have been misunderstood with what I just said, and try to clarify that. And if there truly was a miscommunication, be willing at that point in time to acknowledge and apologize for that miscommunication. What about humor? This is a hot topic and one that I think we all kind of dance around and maybe walk on eggshells around. Humor can be a coping mechanism. It is for me, I know. And humor can be used to make connections with our patients and with our learners. And there have been circumstances where I have used humor in a patient that I know. So I've got some learners that are with me that haven't been with me very long, don't know me very well. My patient knows me better than they do, and I use humor with my patient. And I've been called out by a student on this one time. At least I can remember one time. And when we left the room, the student said, "I can't believe you said that to the patient." And my answer was, I've known that patient for 20 years. I know that patient's kids. And you know, that I don't think the patient was offended by it. Should have asked maybe, but you know, that thing that I said was intentional. I was not making fun. I was not using humor inappropriately. That was intentional in a way in this case to try and soften a conversation that we were having. And therefore it can be perceived as insensitive. And this student perceived it as insensitive on my part, that I was being absolutely inappropriate and insensitive to this patient, who I had some bad news to give, but did it in a way that I brought up, you know, something that was a little more humorous. If you use humor, let your team know and be willing to accept the feedback that they might give you, that they perceived it a little bit differently. And when you use humor, don't use it aiming at specific people. I just told you a story. I was aiming humor at a patient, but be very careful about aiming that humor at a specific person, but rather at the human annoyances that occur. We talked a lot about, Chad and I, when we were talking about this, talked a lot about humor and the ways that we can, that it can be beneficial and the ways that it can be harmful and hurtful. We actually had a teach session a couple of years ago on Barrow's humor and the care with which we ought to be using that. So as we kind of wrap this up and kind of talk about psychological safety in the different settings, in the preclinical setting, I think we're getting right back to the second or third slide on here, that we can create that environment of safety in the preclinical setting, whether it's a PBL facilitator, a health HSS facilitator, or a lecturer, or an OSCE, by setting expectations, by inviting participation, by being willing and giving permission to challenge, and then by providing and accepting ourselves any feedback that might be sent our way.
Okay, so now I'm getting a little bit vulnerable. I'm interested, you only gave one example from your life, and it was a good thing. So one of these that he told me to give, and I'm putting myself out there, so don't get mad at me for this, but I'll tell you what I did. So a couple things I do. This is a good thing, and the other thing was a vulnerable thing where I said something I shouldn't have said, and then kind of how I dealt with it, okay? And then you be thinking about how you want to rail against this or give out other scenarios, because then we'll have time for lots of discussion, which we hope that there is. We can talk about the LEAC, all questions about the LEAC, you can send to him. So flattening the hierarchy, this is what I do. First thing with any team, when I set with the team, I say I have a cardinal rule. And my cardinal rule is that everybody is allowed to ask questions. Everybody is allowed to give opinions. Don't think just because I say it that it's right. I want you to challenge me. And in fact, I tell them, I open up, I said, in fact, if you challenge me and when you challenge me and I'm wrong and you can prove it, I have a high level of respect for you. And that will definitely go on an evaluation. You need to be respectful about it. I will be respectful to you. When you say something incorrect, I will say, I think you meant this. Let's investigate that. But we're just flattening that out, so they're not thinking, oh, he's just a seasoned attending, he's always right, because then that's how I make mistakes. And my biggest pet peeve is, and I tell the teams, is that if I've gone 3 days and I said something that was nonsensical in the chart, And then I realized it was nonsensical. And then I look at the resident or whoever's around and I say, did you guys not read this? He goes, oh yeah, we thought you meant this, but we didn't know and we didn't say anything. I get really upset because I tell them up front that doesn't need to it's like a patient's care. You got to be willing to say something. So right off the bat, first rule, cardinal rule, we're flattening the hierarchy. You're allowed to say things. You're allowed to come up with opinions, and you might be wrong 9 times out of 10. That's okay. The one time might save somebody's life. So I have it come. And then the embarrassing thing, when done well, not done well, but repaired. So shutting down helpful voices. We talk about like students and residents and fellows, but the nursing staff as well. I had a moment a couple months ago, it wasn't my finest moment, where we just went off geographic rounding. So we're rounding all throughout the hospital, and we're in units where the nurses and the staff don't know each other, don't know us as well. And I had a patient scenario where the patient probably was heading toward hospice and palliative, and we were already all over that. We were talking to the patient, documenting communication, talking to the family. And the next day, the nurse, well-meaning nurse, she came up and she said, and I'm rounding and we're talking about this, and she starts talking to me. She goes, well, I think they're confused. I think you should consult palliative care here and what palliative care does. And she explains what palliative care is to me. Well, she doesn't know me, And so what I said, I'm not proud of, but I'll say, I understand the definition of palliative care. And that's what I said. Now that's harsh, right? And the nurse, you should shut down a conversation. And then I recognized when I said it, so I took care of the patient, and I went immediately back to the nurse. I said, hey, I hope you forgive me. That was wrong with what I did. We were frustrated because we were dealing with this back and forth, and this is what I did. And then I went to the charge nurse, and I said the same thing. I shouldn't have said this. This came out wrong. This is my internal frustration came out in my speech, and I hope you can forgive me. And they were so gracious. And now it's like, we get along splendidly. There's no problem. Try being a doctor that says that you are wrong to a nurse. That nurse will be your best friend for as long as you're here. And they will back you up and they will help you. You know why? Because it's kind of rare. And it shouldn't be rare. Okay, so that's psychological safety goes with nursing staff and everybody else as well. And then just so you know, if we didn't hit this hard enough, some of these things, what this does address is the hidden curriculum. There's a curriculum where it's like, well, this is, what's the hidden curriculum in medicine? This is an attending, this is an expert. I don't want to challenge the expert. No, challenge the expert. That's okay. That's how we move things along well in science and medicine. Team functioning, team wellness, just culture. So just culture has to do with looking at systems and saying, what's the process problem? Not that we're going to smash the person that did the thing, but what's the process problem? This is where when this is not done well, like in the aeronautical industry, when they fly a plane into a mountain, because the co-pilot, this has actually been done, co-pilot, there was not the culture where the co-pilot could talk back to the pilot. And so that is just no good for a lot of reasons. So just culture means that if I'm reporting that this went wrong, will I be the one that's like slapped, or will we look at the system and the process? And this happens quite frequently in medicine. And then diversity, equity, inclusion. If you're in a minority situation, you're under a lot of threat. So you have a lot of threat to, do I express my opinion? And just inviting that to come forth. Psychological safety deals with all of this as well. So you see a lot of these things that hits.
Thank you all so much. What a wonderful learning environment it would be if we were all really super skilled in these concepts. If you want to try them out and you're a little hesitant or you want to talk more about it, we do have a super wonderful service that we offer through Teach. It's our observation and consultation service. Chad is actually on this subcommittee, and so you want to talk about it, you want to talk some of these concepts through, call us up, fill out a form online. We will get to you, we will have conversations about how to directly apply it to your situation, or we'll come and observe you practicing, and then we'll give you some psychologically safe feedback for doing so. So enjoy the rest of your day.